Thank you for joining today's PCC webinar on recognizing and incentivizing behavioral health integration. Today you'll hear from two accrediting organizations as well as one coalition of employers about what they're doing today to encourage the integration of behavioral health with primary care and where they hope to go in the coming year or two. Thank you so much for joining us. I'm Julie Schilz. I'm serving as the moderator today. I'm Senior Director of Health Innovations and Clinical Quality Improvement at Mathematica. I also serve as PCC's Executive Member Liaison to the PCC Board. I do this along with Rob Durbin at Merck. Just to share before we get started today a little bit about PCC. It's a nonprofit multi-stakeholder organization that unifies and engages diverse stakeholders, promotes policy, shares best practices like on a webinar you're engaging in today. It's a membership organization. It has grown so much in the last few years because of the staff and leadership at PCC. Over 60 organizations committed to the mission in supporting primary care. It's dedicated to advancing an effective and efficient health system built on a strong foundation of primary care with the focus of being patient-centered. Some of you may be new to listening in on a PCC webinar, but I'd like to share with you membership opportunities. Mathematica is a member, and I've been lucky enough to work at several different organizations in which we have been executive members. So membership includes contributing to PCC's policy and advocacy, comment letters, position papers, various work groups, helping to share in the direction of PCC, raising the visibility of your organization at conferences, meetings, webinars, and also access to relevant registration discounts, exclusive content, and workshops only for executive members. Two things happening this year that are really exciting. So save the date for PCC's next annual conference. It will be held in DC on November 5th and 6th. And as all of you may know, that is right after the election. So it always serves to be a really great time to attend the conference because usually there's a lot of opportunity to talk about the results of the election and what it might mean on healthcare. The other opportunity this year is the annual evidence report, 2020's annual evidence report. This is something that PCC does every year, and this year the focus will be on primary care investment. Really great topic, and it's sure to be a wonderful report. So I'll move to some housekeeping reminders just to let everyone know the slides and the recording will be available after this webinar. It usually takes PCC about 48 hours to get it up onto their website, but everything will be available to you. All lines are muted, so if you have a question during the webinar, please put that in the chat room, and I'll be monitoring that and try to get everybody's questions at the end. Let's see, I think that's it. So with that, we have a wonderful group of panelists today. I will tell you they have extensive and relevant CVs, but they've been gracious enough to let me quickly introduce them, and then we can have them move to the presentation. So our first presenter is Michael Barr. Michael is a board-certified internist and executive vice president for the Quality Measurement and Research Group at NCQA. Prior to joining NCQA in 2014, Michael served as the senior vice president for the Division of Medical Practice at the American College of Physicians. We also have Shawn Griffin, who's the first physician to serve as president and CEO for URAC, a nonprofit accreditation organization based in DC. Before taking the helm at URAC, Shawn worked at Premier Inc. Our last presenter will be Mike Thompson. Mike is the president and CEO of the National Alliance of Healthcare Purchaser Coalitions, an association of approximately 50 regional coalitions, collectively supporting over 12,000 healthcare purchasers, providing health coverage to more than 45 million Americans. So with that, we will get our presentation started, and I will turn it over to you, Michael.
Thank you, Julie. I'm going to, perfect. Thanks for advancing the slides. Thank you very much for the opportunity to speak to all of you today. I know most of you are familiar with NCQA, but I thought it would be helpful to give like a 15-second quick overview. NCQA is 30 years old. Most of you know us in this context about recognition programs. I'm sure you all know about HEDIS and health plan accreditation. What you probably don't know is that we have a nice and growing portfolio of federal and state contracts around measure development, application of the recognition programs in the state environment, such as in Tennessee and New York, HRSA with FQHCs. We do a lot of research and analysis on health equity, patient-reported outcome measures, social determinants. But I'd love to come back to this audience at some point in the future and talk about a digital measures strategy, try to improve measures, make them more relevant and useful for some of the programs, such as the behavioral health program and the PCMH program. So with that, today's topic is behavioral health integration and distinction in the PCMH program. And, you know, if you had asked any of those of us who worked on the joint principles 13 years ago, my colleagues from family medicine, pediatrics, and the Osteopathic Association, that we'd be talking about medical home 13 years later with all of its implications for primary care transformation, we would have not believed you that we'd be doing this. So it's really an honor and a privilege to have been part of this for so long. Since NCQA's program on behavioral health integration is firmly based on the foundation of the PCMH, I think it's important for me to just give you a bit of statistics related to the PCMH program before diving into the behavioral health distinction. So NCQA's recognition program for PCMH has about 50,000 physicians across the country, about 70,000 total clinicians, and over 14,000 sites. And when I looked at the statistics this morning, we have 21 states for which 20% or more of the eligible physicians in that state are in a practice recognized by NCQA. There are 10 within 15 to 20%, and then 6, 10 to 15%. So as a foundation for behavioral health integration and the distinction, the NCQA PCMH program is probably pretty unique. So here are the current statistics. Actually, I was just informed by Christina Borden, who's joining me today. Christina is the Director of Product Development. And because of my schedule, she'll hang on to the call and answer questions towards the end. But Christina informed me that we have now 174 distinguished sites in the PCMH program across 30 states. And what's important here is the practices range from a solo clinician to 85 clinicians in a practice. The states with the most distinctions include California, Maine, Tennessee, and Florida. And as I'll note in a moment, Massachusetts has a forerunner of this program called PRIME, and there are 40 practices in Massachusetts that are recognized under this project. It's not a new program in terms of the idea of incorporating behavioral health into the PCMH program. We've been focused on it since 2011 and continue to push the bar with each iteration. You'll notice in January 2016 was when we introduced the PCMH Prime in collaboration with the Massachusetts Health Policy Commission, and that's the 40 practices I've referenced just a couple of minutes ago. But it's been a part of the project, and I know one of the challenges that practices have is sort of integrating is sort of incentives and support and technical assistance. And I think with the PCMH program, part of the success was that there were these incentives. So here we have a part of the PCMH program around behavioral health that you heard 174 distinguished sites among all those other practices. I think one of the challenges is making sure we promote, incentivize, and drive the kind of change at the primary care to incorporate this, because I think the trajectory here is clearly not as steep as it was with the PCMH programs. But we're very excited about it. We are very supportive of this. We added the distinction for annual reporting in July of 2019, and we continue to teach about this product and the programs and its implications for better care. Practice in the PCMH, the intent is to integrate behavioral health and support primary care. The practices stand out. They demonstrate to patients, payers, and partners that the practice of the right resources, evidence-based protocols, and standardized tools. And we do believe that it will improve outcomes for people since behavioral health challenges affect so many people that are treated in primary care settings. The next slide sort of highlights the key components of the distinction of behavioral health integration. If you start in the upper left, it's sort of behavioral health workforce. Does the practice have the right people or in-house or relationships with external behavioral health providers, the appropriate training? We don't require them to add on new staff to distinguish themselves, but to leverage their existing team members and training of those folks to adhere to the model. A lot of information sharing is important, so how practices share information is part of this. It's actually part of all of the recognition programs, PCMH, this distinction program, the patient-centered specialty practice recognition program, which encourages information to be shared to help take care of people, not for the sake of sharing, but to really support better integration and seamless care. Clearly, anything we do should be evidence-based and built upon the evidence and continue to contribute to the evidence, and then monitoring to make sure that the practices are actually delivering on the care that the criteria suggest they should be delivering on. Now, this slide, I want you to focus on the center of the slide to start with. These are the criteria that are in both the NCQA PCMH program and the distinction in behavioral health. And on the left-hand side are all the it shows where these criteria fall in terms of the requirements of the distinction. But I think the most important part is all of these are part of the PCMH program, and they are treated as elective criteria. So NCQA in 2017 modified our program so that there are core criteria and elective criteria. So a PCMH program or practice that wants to go through recognition can actually focus on these things as part of their electives. You'll see depression screening is required, as is evidence-based support for mental health conditions and substance use disorders. Those are criteria within a required set of criteria, so they don't have to use these to satisfy that particular criteria, but they can if they want to. I guess the take-home point from this slide is that a PCMH under NCQA's recognition program is already nicely set up for behavioral health distinction if they so choose to use those criteria that are elective in the PCMH program, but required in the distinction for behavioral health. There are some additional criteria that are required for the behavioral health distinction, and those are in bold on this slide. So a clinician who can directly provide brief interventions is required, behavioral health referral relationship is required, information sharing, behavioral health referrals, tracking and monitoring, closing the loop to make sure people get the care that they need. And you'll drop down to the measure and monitoring area. You can see the monitor symptoms and adjust treatment plan and monitors performance and behavioral health measures. So there's all those required to supplement the PCMH bedrock foundation of primary care transformation. Part of the 2017 change to our PCMH program was initial recognition and then annual reporting. We did that because of feedback from stakeholders in the communities that practices, while well-intentioned to sustain the recognition elements, often sort of because of turnover or other priorities, did not continue to perform at the level of their initial recognition. So it created this transformation phase, the initial recognition, and then ongoing success by doing annual reporting. This is to show that practices, we recommend that practices that want to come through the behavioral health integration distinction do it as part of their normal course, either as part of their initial recognition when they come through the annual reporting to report on those criteria that I highlighted in the prior two slides to distinguish themselves in behavioral health. Annual reporting is a unique feature of our program. We think it differentiates NCQAs from other programs because it shows that practices are remaining engaged and are continuing to improve upon the foundations that they set up when they became initially recognized. Now, all of our criteria for behavioral health integration as well as PCMH are available in the NCQA Store for free. The first time you get it through the store, and then there's a download center for subsequent downloads as they update the criteria or versions change. This become available to those who have licensed it initially. And we're welcome to answer your questions either now at the end of this webinar, or you have, my email is barr@ncqa.org, but Christina's and Paul Cotton's, who's our Director of Federal Affairs and very well versed in this, are on this slide for you to email us questions if you like. Thanks for the opportunity to present this to you, and I look forward to hearing from you. Back over to you, Julie.
Thank you so much, Michael. And with that, I will turn it over to Shawn.
Good morning, everybody. I'm Dr. Shawn Griffin. I'm the president and CEO at URAC. I'm very honored to be the first physician to be in this role as the president and CEO at URAC. As an organization, one of the things that I want to emphasize is the NCQA program is a wonderful program. I was previously at the Memorial Hermann Healthcare System, and I helped over 100 primary care physicians go through the patient-centered medical home program. And I think that it did a tremendous job of helping our primary care physicians both to staff up and raise the quality of what they were doing as an organization. I think today, with the emphasis being on incentivizing behavioral health and recognizing behavioral health integration, I just wanted to highlight here the URAC programs. This is all the programs that we offer, and one of the things that I'm very excited about is at the bottom right is the Mental Health and Substance Use Disorder Parity Program. This is a program which we picked up at the end of last year, and we recognize this as being a key component in going forward when we look for areas where we can incentivize performance within behavioral health care and substance use care. Having a program specifically focused around those two topics, we think is key for getting the incentives aligned for organizations. But we've been doing this for 30 years. We're actually across the street from NCQA. We have a very strong role in pharmacy, so opioid therapy, substance use disorder, a lot of the case management as we started out all those years ago. But this is just our current suite of programs as we enter our 30th year. We have a 30-year history of accreditation, as does NCQA. We have extensive experience with the pharmacy benefits and the standards, and that way when we look at behavioral health components, we have the ability to write in standards within behavioral health, and they can be within pharmacy standards, within health utilization standards, within utilization review standards, and we really offer this comprehensive way of complementing our programs to where a provider who's looking at standards within one program can know that there are standards along the same lines in another program. And we think that that alignment throughout the healthcare universe, everything from providers to payers to utilization review to legislative programs. We have multiple government deemed programs demonstrating our support and integration with government standards. We want to be supportive of the regulatory environment that we all operate in, but we also recognize that sometimes the regulations are simply setting the bar for safety and they're not really highlighting quality. And we think that this is an opportunity also for us to bring in our prominent telemedicine, telehealth programs, because when you're getting into behavioral health, you're getting into network adequacy issues, you're getting into access issues, and we think that telemedicine and telehealth will be keys for improving those competencies. I would be remiss if I didn't mention that we're also the largest independent creditor that doesn't sell consulting. We think that consulting sometimes can be a conflict of interest for people going through the accreditation program, and so we just don't do that. I think that when I think about how behavioral health comes into primary care and how it functions within the healthcare landscape, I want to go back to my own experience as a physician. I trained in rural family medicine in Iowa. I practiced for a dozen years. I was in Missouri, and then I was in Texas working with physicians, and medical and behavioral care were paid and regulated as though there was no relationship. The classic term about a carve out for behavioral health. And if you were primary care physicians, you wouldn't be paid for providing behavioral health care. And as physicians, we always knew that that was an artificial distinction. And it created what I call kingdoms of care. Some people will talk about silos of care. Well, honestly, I grew up in rural Iowa, and I've seen a silo, and a silo is a passive grain storage bin. And there's nothing in medicine which is passive. And I'd say it's kingdoms of care or castles of care where people are defending their turf, and usually it's ruled by somebody who's trying to protect their interests. But for physicians, it's not about protecting their interests so much as it is trying to provide an integrated version of care. And patient-centered care, whether it be part of patient-centered medical home or whether it just be part of what you go into as a physician, you recognize that you have a relationship with the whole person. It's not that somebody starts talking to you about their cancer and they start worrying about how they're going to pay for it, or they're talking about their depression. You go, oh, I'm sorry, that has to go to some other provider. We don't segment people. We take care of people. And the other thing is that for years, the employers, if you're talking about anything behavioral health, the employers sort of like it was they were stepping into a minefield and they were afraid to go there, and they didn't know how to be involved, and they sort of entrusted it to the payers to solve the problem for them. And sometimes that meant that the patient didn't get the care that maybe they would have gotten otherwise if this was a sprained ankle or a broken leg, because it was, you know, a depression or substance use disorder. And we really want to make sure that as we do these things, as we look for incentives, as we look for alignment, that it's really about breaking down the barriers and working with people who recognize the whole patient as the person going through care. Recently, I was fortunate enough to participate in some work where they were talking about the reset framework, and I believe the National Association of Healthcare Purchasers, Mike Thompson, is going to be talking about this in his slides. But when you look at the 5 areas that reset has talked about, the measurement-based care, the mental health parity compliance, telebehavioral health, collaborative care, and network access, I believe URAC is the only national organization who has solutions and standards in each of those framework areas. And our integrated behavioral health program and how we build that, you know, we recognize that we have to bring everybody to the table. You have to bring the constituency groups, you have to bring the payers, you have to bring the employers, and you have to bring the patients all together to make sure that you're creating something that meets people's needs, and you're not so swung in one direction that you leave off the other parts which are important to this. So we work very actively with our constituency groups to put together our standards. We put them out for public comment. We track that process to make sure that what we're doing actually meets patients' needs and isn't a standalone program where we leave out something that's very important for care to be delivered. My final thoughts, with the idea of behavioral health, you have to recognize that there are multiple approaches to coordinating care. Some of the programs are going to come from starting at a hospital basis, some are going to come from a payer basis, some are going to come from a carve-out basis, and you really have to provide a glide path to where you're bridging between the current program status and the kingdoms that are currently separated to a unified vision of integrated behavioral health to really serve the patient. We believe that our pharmacy programs provide a unique opportunity so that our substance use disorder program is integrated with behavioral components of care. And the fact that we are the leading accreditor for specialty pharmacy and mail order pharmacy allows you to have that completion of information. We think that employers are acting as the drivers right now, and their focus on the whole person is a way to get towards the costs, because if you treat behavioral health as though it exists in its own area, you miss out on the fact that it contributes to greater costs in almost every healthcare area. We think that the mental health parity law is going to be of increasing importance over the next several years, as there are now a new incentive for payers, employers, and patients to work together to have a national solution, so that you don't have regulators in one state trying to address mental health parity in one way and it's different in the state just a few miles away. And no matter what we do as accreditors, we recognize that the best programs have to continue to evolve to match the needs of everyone, and that this is a time where you want to share your best practices and you want to make sure that everybody is working together to raise the level of care, and you're not just creating a new island or a new kingdom. And with that, I will turn it over to Mike Thompson.
Hi, this is Mike Thompson, and I'm with the National Alliance of Healthcare Purchaser Coalitions. And go to the next slide. And just a little bit of background on us. We're the only nonprofit purchaser-led organization with both a national and regional structure. As you heard in the introduction, we represent over 45 million Americans, but we represent a cross-sector of private sector companies ranging from 60% of the Fortune 100 and many mid-sized and smaller companies as well. Public sector entities like states, cities, school districts, even the federal government, as well as union organizations that provide benefits like UAW or the UAW Trust or 32BJ. So it's a very diverse group of entities. Next slide. Our general approach is really in this context of lead, leverage, localize. Lead in the sense that we believe that purchasers set the agenda for how to move the system forward and influence the stakeholders downstream, whether it's the health plans, the providers, and other key stakeholders moving forward. Leverage in the sense that we are able to do innovation region by region and then leverage what we learn in those innovations across the country. We have the railroad tracks essentially built to our coalitions across the country. And then localized, being able to adapt and understand the unique market dynamics across the country, whether it's in major cities, New York City, or Washington D.C., or rural states like Wyoming or New Mexico or Maine or Alabama. So very, very diverse, very unique. We are engaged in a lot of key areas, one being advanced primary care and another being mental health. And I can tell you, based on recent efforts in advanced primary care, we have taken a position that integrating behavioral health is a core requirement for advanced primary care from a purchaser perspective, that it isn't advanced primary care if you haven't integrated behavioral health. So we're not wishy-washy. We don't see it as a distinction. We see it as a key requirement if you're going to meet purchaser requirements for advanced primary care. Next slide. But on the mental health front, we have a major initiative that we're undergoing, looking at mental health and substance use as really a public health crisis. I mean, we have major access issues that employers and employees and their families are experiencing to get to specialists. There's huge provider shortages, and those providers are not consistently participating in networks, which is causing major access issues and the worst access issues, frankly, for the people in crisis. We know that most mental health medications are prescribed by primary care, but the level of integration of behavioral health in primary care is very inconsistent. And then there are concerns around mental health parity. And so our goal is to help reverse that. And we're focused on 5 areas, a number of which are relevant to this audience. Collaborative care, integrating behavioral health through the collaborative care model, measurement-based care, providing a more professional and consistent approach to behavioral health, both in primary care and in specialty care, network access, parity compliance, and finally telebehavioral health, which we know is going to be critical for 2 reasons. One is the geographic access to specialists very substantially across the country. And then secondly, we know that in primary care, many of the practices are not big, large groups, and we need to have a way to provide virtual access to behavioral support as appropriate. Next slide. So we're taking a very disciplined approach to moving an agenda forward in those 5 areas. It's called the Path Forward for Mental Health and Substance Use. And it's a collaboration across 4 actually entities: the Meadows Mental Health Policy Institute, the National Alliance of Healthcare Purchaser Coalitions, the American Psychiatric Association, the APA Center for Workplace Mental Health. It is focused on bringing technical resources from a national perspective to the table in those 5 areas, leveraging key change efforts in 8 reset regions, which are essentially multi-stakeholder change initiatives that are working a disciplined process to make sure we're taking the necessary steps to achieve measurable improvement in those areas, and then leveraging it across all of our coalitions across the country to help change the market to demand those elements that are critical to achieve this. So again, the voice of the customer, helping to lead the change, understand what's required, what are the barriers getting in the middle, and then facilitating and demanding those changes across the market more broadly, looking across the entire supply chain. RESET, just so you get the broader context, stands for Regional Employer Stakeholder Engagement Team. So that is our initiative to move forward. If you go to the next slide, we have 8 reset regions that are launching as we speak. California, which is led by 2 coalitions, our Pacific Business Group and Silicon Valley. Florida, led by the Florida Coalition. Kansas by the Kansas Coalition. Maryland, DC, and Northern Virginia is led by our Mid-Atlantic Business Group on Health, and that's in collaboration with the state of Maryland as well as MHA of Maryland, Minnesota, New York City metro area, including Northern Jersey and Southern Connecticut, Tennessee, our 2 Tennessee coalitions, and Texas, our 2 coalitions in Texas. So with that, I'd be glad to respond to any questions.
Great. Well, thanks so much, everyone. We have a lot of time for questions. We've gotten some questions in the chat. This is actually quite exciting that we have so much time for questions for our panelists. And we will, from an NCQA perspective, we will be having Christina Borden join us to answer any questions. But I'm going to put out a question to all of our panelists, and maybe you can answer them in the order that your organizations presented. But, you know, I work in the space of quality improvement in healthcare, and one of the things we say is make the right thing the easy thing. And I'm curious, from all of your perspectives, what do you believe have been the 1 to 2 biggest barriers to that affect the integration of behavioral health and primary care to date? And Christina, I'll start with you.
Sure. So hello, everyone. I think for us, the way we approach the design of not only the PCMH program, but looking at behavioral health as well, is really starting with the team, starting at the workforce level to make sure that everybody that will come in touch with those patients understand what their needs are. And behavioral health patients do have, you know, in many cases, complex needs that the staff need to be trained around, and understanding like how the communication is with those patients and doing the warm handoff. So I think one of the key areas of development for practices is really getting their team on board from the very beginning. And then I think looking also at quality measurement, looking at those specific measures related to behavioral health. We're getting more and more data around that, but to continuously monitor, to look to where there are opportunities to improve at the practice level.
Great, thank you, Christina. Shawn.
The thing that I would say is that I think that there's the continuous challenge of, as long as behavioral health is being kept separately for incentives and for reimbursement from the regular care that's being delivered, the offices and the administrators and the finance people just did not have the same sense of urgency in addressing it. You know, if you're a physician and you're sitting down and you're looking at your quality measures, it's very rare for you to have a quality measure as part of your incentive plan that is tied to behavioral health, because, you know, if you're not paid for it, if you can't drop the code for it, then you're not going to be focused on it. So your offices and your staff are going to be much more focused on the things where you have an incentive tied to it. And I think that has been a tremendous barrier. And the fact that, you know, when you begin to hear that behavioral health matters, I mean, the physicians and the frontline people who are delivering the care always see the behavioral health issues. They come in the door, and sometimes they're what I would call the doorknob problem, that is, as you're about to leave the room and you have your hand on the doorknob, then the patient brings it up. And you know, that's not what they're making the appointment for. Sometimes there's embarrassment. Sometimes there is just a hesitancy to bring it up with your provider, because very often we think that the patients begin to self-divide their care. They think, I'm sitting down with my primary care doctor. Oh, wait, I have a behavioral health specialist, which is a different box. And so they don't bring it up. And when they do bring it up, the doctors don't have necessarily the training. And that's why training programs are so incredibly important, and having meaningful measures and not just more measures is incredibly important. But then breaking down the walls between the incentive programs really will help with the alignment. If you paid all primary care physicians an incentive to do a good job on measure-based care for behavioral health issues, you would see that needle move. But as long as those things are kept completely separate and sometimes treated as though they're a financial distraction and not a core part of caring for people, you just have more challenges to overcome, and it all looks uphill to the providers.
And this is Mike
Thank
Thompson.
you.
And I'll just build on that just a little bit. You know, I think part of it, as I understand it, has been kind of structural. The incentives, the payment mechanisms, they largely haven't been there until the last couple of years to integrate behavioral health, the collaborative care model, into the system, efforts to kind of implement broadly advanced primary care, collaborative care into primary care have been handicapped by not having codes and things like that. Those codes now have been approved, and frankly, they're being paid for by the great majority of the payers right now. And so that's an issue. I think the other part is this cultural issue that I've heard where oftentimes dealing with behavioral health issues is complex in primary care if there's not the necessary support structure in play. In fact, some primary care physicians said, you know, if you have somebody who is having serious behavioral health issues, you're concerned about treating them, because if you treat them, what do you do if you need to refer them? Who do you refer them to? The relationships aren't in play. And what if they kind of break down and kind of take a lot of your time and kind of can mess up the rest of the day in a busy primary care office? So it's a challenge. I do think that the good news is that every organization that I have heard that have gone to integrating behavioral health will never go back, because they know it's better for patients, and frankly, it's better for the providers as well.
Thank you for that. And I do want to mention, I didn't mention this in the opening remarks, that PCC does have a behavioral health work group. We have lots of amazing questions in the chat box, and I'm going to hope to get through all of them, but it would also encourage everyone on the line to consider joining that work group as well. So we have a question from Beth, and her question is, what do you see in the future relative to breaking down barriers in information sharing in behavioral health care and primary care? I know that, you know, one of the elements that has been frustrating for providers and staff are how the rules for HIPAA have been considered, and that there, in some cases, it's felt that the information sharing can be a little difficult. So I welcome any one of our panelists to respond to this question.
Well, this is Shawn. I'm fortunate or unfortunate, depending on how you look at it. I spent about 15 years as a CMIO, and part of my career was trying to get the electrons to play nice together and for that information to get shared. I think that for years we suffered from a number of people who looked at medical data sharing, and they were what I call hypochondriacs. They were always afraid that appropriately sharing information would be a HIPAA violation. And for most medical situations, that's just not really the case if you're really using it for care. But when it comes to mental health, you know, there are some legislative and regulatory silos for mental health care. And really, it's interesting that those are getting broken down more and more by the fact that we're saying we want providers to assume risk for care of patients, and they're recognizing that mental health care and behavioral care is such a key component to the contributors to higher cost patients and to silos of care and those things, that those rules are probably going to get revisited, and those rules will get changed so that we can take care of people, the complete person, and not just the partial pieces of data that we're allowed to share. So I think that we're probably going to have some regulatory fixes to get those things shared, because you can't find providers who want to take risk on a population when they don't even know something that's important for 40% of the population, which is behavioral health.
Yeah, and just to add to that, I think we're also seeing a movement when it comes to how we're sharing our information, just personally as patients, and what we're able to do and advocate as an actual patient as well. And so those privacy barriers seem to be really coming into question and potentially being able to be broke down from a patient perspective as well.
This is Shawn. One last thing I want to throw in on this is that the opioid crisis and the pain that all of us have seen in our communities and with our loved ones around substance use disorder. I think that we recognize that the stigma that was associated with this care in the past, we can't let that be a barrier to saving lives and to treating the people that we love. And so I think that the societal stigma around this also has lessened, and that has allowed us to have a more open conversation about how we need to care for people and not let these artificial barriers stop us.
Thank you, Shawn. That was a great addition. I'm going to throw out a question to all of you, and maybe we'll go in reverse order, and I'll start with you, Mike. But from your perspective and with your constituency, have you seen any states or that you've seen as leaders in this area, and any innovation in programs or financing?
Yeah, I think that I don't know if it's states per se, but a lot of the leaders in behavioral health integration have come from the large group practices, often hospital affiliated. Montefiore in New York has been a leader, a national leader in this area. Recently, UPenn has implemented and found great success in its implementation, and a lot of it does relate to the fact that the collaborative care codes have been approved, and I think people are starting to become more aware on how to implement a more disciplined process for managing mental health within their practice community. I think the other big innovation that is happening in this area is the ability to provide virtual consults and virtual care. There's innovators across the country that are starting to work with primary care practices as well as others to support them in the behavioral health integration in ways that we probably couldn't afford if we relied specifically on co-location. And because of that, I think the bar for integration is, because the barriers are coming down, the bar and expectations around behavioral integration are actually being raised at the same time.
This is Shawn. Just to go second, I would say that there's really two sort of nests that I'm seeing. I'm seeing the areas, UPenn and their presentation that I heard them give recently about what they have done for the integration of behavioral care and the codes and those things. You're seeing sort of leading primary care groups who are recognizing that there are now new tools that they can use to address behavioral care. The other place where I would say is that when you look at the large organizations that are taking on risk for populations, whether it be direct to employer contracting or maybe some of the value-based care areas, when they start getting the full claims information and they start taking risk on the cost of a population, it becomes very clear that you have to have an integrated behavioral health approach to really address those drivers of cost, and people who have care management systems and those things, that's really where I'm seeing the catalysts going for this. I think there are some states that are moving, but they tend to move in more isolated areas. I'm very excited to see the employers sort of stepping up to the plate and driving some of these things. So that's what I'm seeing.
And this is Christina. With our experience with, who we have recognized with the behavioral health distinction, we, have some pocket states like California and Maine that have really been driving through larger health systems for that distinction, but also with the Massachusetts Prime program, that really was the initiation of really thinking about like how we can integrate this into a primary care setting, PCMH setting, because there's all those levers that they're already pulling to get the patient-centered medical home up and running, and training their teams and getting all of those what seem to be obvious pieces into place. And so just incorporating it at that level with how they're doing it around behavioral health seems like a natural fit. And so with working with Massachusetts, that's where we were able to see the crossover. But I think just based off of what Shawn was saying, we'll see more as more incentives come up. I know both with our work with New York and Tennessee, you know, they've really been focused on getting practices to be the patient-centered medical homes, and then are looking for opportunities in other areas to drive future work to encourage moving towards the value-based initiatives. So.
Thank you. And, you know, Mike, I know you mentioned Montefiore, and one of the interesting opportunities, you know, one of the things Montefiore did was participated in the CMMI program TCPI with the National Council on Behavioral Health. And, you know, the other opportunity is sort of utilizing some of the national programs, participating in them, because they usually come with quite a bit of technical support to be able to support a variety of different initiatives, even including behavioral health. So we have an interesting line of questions that's sort of surfacing virtual care as it relates to both primary care and behavioral health. So Mike, I'll go ahead and maybe start the question off from you and just get a sense from your perspective and your constituency's perspective, what might the role of virtual care be in the, you know, being able to provide services to employees?
Well, you know, the evidence on virtual care, telebehavioral health, is actually turning out very good, that the care being provided through telebehavioral health is as effective as in-person care in this area, you know, not necessarily for all care, but in this area. And in some states, there could be one psychiatrist in a whole state. And that, of course, is hardly adequate to support the mental health and substance use needs within a state. It's one of the reasons that it's so essential that primary care step in and play its role to treat what it can in this context. But secondly, it's where virtual care plays a major role, where by being connected into a system that may be virtual, that can support both from a consult standpoint, but also from a treatment standpoint, for that care that does need to be referred on, is critical. And what we are finding is some of the new technology vendors are also helping to support the mental health service provider collaborative care coordinator model, if you will, for primary care as well. So the idea that the way we've learned it and now are telling purchasers is, you know, co-location is not enough and co-location is not necessary, right? So co-location is a nice to have, and certainly in bigger practices, that probably is the way those bigger practices will go. But I think in smaller practices, it's not even an option. And so the question is, how do we integrate behavioral health in a virtual way with service providers that are being built in that manner to support primary care in that way?
We've also seen it very successfully used when it comes to rural practices that really want to focus on supporting their patients when it comes to behavioral health with access related issues. So that's just another area that when it comes to telehealth, we've seen really be supportive in this direction.
And this is Shawn. Let me throw my voice in on this one. I had the unique opportunity that early on in my training, there were times where I was the only doctor in a county in Iowa delivering care. And then later in my career, I was in Houston, Texas, where you can't swing a dead cat without hitting a doctor. And I think that you need to recognize, I mean, co-location has a place where it fits, but there's other places where telemedicine right now is going through a tremendous transition. It's going from the how do I connect my device to your device, to where you can get in to see a doctor, and you're seeing organizations that had a very department-specific solution that they were rolling out, to now where it's becoming a system solution, and you're seeing these national vendors, and you're seeing it incorporated into care and those sort of things. And I think that clearly telemedicine and telehealth and telebehavioral health and all the various versions of it are going to be a key for network access and for emergency access, both in the rural underserved, but also in the urban underserved areas, because even if I have 600 psychiatrists within a block of me, if none of them are in my network and I can't get access to them, I am underserved. And so I think that clearly, the telemedicine and the extension of the specialists, but also the schooling up on the primary care physicians, so that they can take care of the more straightforward cases, or the ones that are coming in their office every door and they know when to refer, I think is all part of the solution that we need to have. And I think that if I were talking to organizations out there on the phone right now, I would say, don't reinvent the wheel. This is one time where there are experts, there are areas of expertise around the country where you can sit at the table, where they're happy to share their experience, because this is something that's too valuable for us to sort of feel our way through the darkness for the next 5 years till we find the solution that works for us.
Thank you. Another area where the questions are coming in on are related to measures, and I'm going to combine some of the questions in the chat are a little bit about just the practicality of this work at the point of care, and no one's dismissing that it's critically important work, but in a day to life of providers, it can be a little bit difficult. And as HHS and CMS are focusing on burden reduction, I'd love to hear from all of you. And Christina, maybe we'll start with you in terms of where you might see the overall question is, where do you see measures going? And feel free to add, in some of the new work related to digital measures as well, but would love all of your opinions related to measures in this space.
Sure. So I think for a very long time, we've been, familiar with the typical types of measures that practices are reporting on, and it's definitely been less in this space until more recently with looking at depression and other areas. But we're really trying to, and we go through a similar process as URAC when it comes to the development of our programs and our measures. We put things out there for public comment. We bring all the stakeholders and patient groups and associations to the table to really look at what the direction should be. Are we capturing something that's meaningful and actually measurable for practices? So we will look as we learn from those that are becoming distinguished in this space, what those specific measures are to kind of drive what the vision should be going forward. I can't specifically share what we're doing around digital measures. Unfortunately, Michael has that intelligence a lot more than I do, but we would be happy and hopefully be able to do that in the near future. But really just focusing on what is meaningful to practices, because there's a lot you can report on when it comes to measures, but we want to be reporting on the right things.
Great. Shawn, anything to bring your perspective related to measurement and measures in this space?
Absolutely. So, I mean, I was a CMIO for all those years, and I watched sort of the glacier of measures move in and crush a number of providers. And I think that meaningless measures are one of the contributors to provider burnout. And as we do this, I think that the NCQA model for having stakeholder input is incredibly important, because doctors do not want another measure. They want a measure. physicians believe that measures should be the exhaust that comes off the work that they do, and it should not be the work that they do. And patients are tired of having the provider have to pay more attention to the click boxes than to their concerns. And we have to make sure that what we're doing in this space is where the measures are both meaningful, but they also can't be the focus as to what everything is going on. Physicians have spent their whole training and their careers passing tests. And so if you give them a test and it's a meaningful test, and they can do well on it. And I think that's what we need to do with the measure standpoint. It needs to be not the goal, but it needs to be the exhaust from the work that they do. And provider burnout never helped with network adequacy in any way. And so we have to make sure that what we're doing cares for them as they care for us.
This is Mike. The only concern I would say in this is that, and this is happening broadly, not just in primary care, but in specialty care. There's a lot of care going on and not a lot of measurement going on as it relates to the patient themselves, the PHQ-9 or other instruments, to understand the severity of the condition at the beginning of treatment and the ongoing improvement in care as treatment progresses. And frankly, that's happening today in primary care as drugs are being administered in primary care, and the follow through is not there to understand whether those drugs are working. We know that there are practices that once they implement measurement-based care, improve outcomes by orders of magnitude, 40%. And I don't think we would ever assume that you can practice primary care without taking blood pressure and temperatures. And I think in the behavioral health area, there are similar valid instruments that need to be utilized moving forward. And that is what we are emphasizing. I know there's an issue of burnout, but frankly, we wouldn't discard these other instruments simply because they're more difficult than just looking in the mouth or touching the forehead, right? There's a better way to provide care, and I think we all have to raise our bar to meet the new standard of care in this area.
Mike, I would agree with you. I would just say that we have to recognize the burden on providers when they have inefficient tools and we're wanting them to deliver care in a more efficient manner. So I completely agree with you, and I think that we need to have measures that are out there that are meaningful both to the patients, and I like looking at the outcomes measures. I think physicians have gotten tired of some of the process measures where they feel like they're just checking boxes and they don't see the impact on patients. And so I think that that's one of the things that we need to make sure. The other thing, just to throw out there, is that the measures need to not be expensive for organizations to adopt. You can't have measures, measures are becoming like generic drugs to where all of a sudden something that used to be free now is costing you a ridiculous amount of money. And so we need to make sure that our measures are publicly available and that they contribute to the care and aren't a burdensome distraction. So Mike, I agree with you.
Well, I just want to thank all of you, give you a virtual thank you for contributing to this critical dialogue. I think that will be the last question that we have, but I want to remind everyone that there are opportunities to become members of PCC, Primary Care Collaborative. And as I indicated at the beginning of our presentation, the webinar, the recording, the slides will be available on the PCC website. Give the staff maybe 24 to 48 hours before they're updated and put on the PCC website. I also want to acknowledge there were some fabulous questions that we didn't get to today, but I think we can move them into the primary care work group at PCC. Some of the questions were around collaborative care codes that it seems while they exist, there's some workflow opportunities that there's some cumbersomeness to them that, there could be opportunities to talk through to be able to offer insight. Quite a few questions around incentives and behavior, in the line of behavioral and economics, and in terms of thinking about different payment, what's the right way to think about different incentives. A few questions around population health, looking at the populations, whether they are within more of a commercial employer-employee perspective, as well as community health centers and FQHC. So thank you to those of you who listened today who really sent in some thoughtful questions that we can then take into PCC. So with that, I will end our webinar. Thank you so much for joining us, and hope to have you join us on the next PCC webinar. And thank you to our panelists.